Hello everyone and welcome to today's webinar. It's me Samagya Bhattrai, an optometrist by profession. Today I'm here with you as a host for the iTalks program by Mero Eye Foundation, and I feel so privileged to welcome you all for this session. Before starting our webinar, I'd like to inform you all that we'll be conducting discussion sessions at the end of this webinar. If you have any queries, then you can just write it down in the comment box below. Today we are here with a case presentation. Our topic for today's webinar is Let's Fight with Amblyopia, a case presentation. And as a speaking delegate, we have Mr. Puneet with us. He is a co-founder and CEO of Curse. Hello, Mr. Puneet, are you there?
Yeah,
Okay, so now I'd like to hand over the session to you. It's our immense pleasure to hear from you.
thank you, Samagya, for the beautiful introduction and to the entire team of Mero Eye for this opportunity again. So, I think we should not waste any more time and start right now. So, the topic for today is Let's Fight Against Amblyopia. So, we have a fight going on since last many years against amblyopia. Amblyopia is a condition that arises mainly into children and even in some adults and the basic older age too. So, I'm today going to discuss a case related to amblyopia only and how we should fight against amblyopia in the newer and advanced approach. So I have no financial disclosures and no conflicts of interest. I would like to acknowledge the team of Cure for Eyes Gurugram and to the patient for media consent. So let's start with a quote by Dr. Nancy Togerson. She quoted that if I had a magic wand, I would get rid of all the Snellen eye chart used in school vision screenings across the United States. Why? Because the test originated in the 1800s and is great for looking at a small and static symbol at around 20 feet away, but it's in no way a reliable measurement of the visual needs your child has for learning, life, and sports. So we always need to quantify the quality of vision, how much quality is the child getting, how much quality is the patient getting. Okay, the quality of vision we should be focusing upon rather than the quantity of vision. So before beginning with the case, I would like to explain amblyopia a little. So to give everybody a brief introduction, I would like to begin by my famous quote saying our eyes function just like a camera. Just how a camera captures any image and then it gets printed onto its film, the same goes on into our eye. We see and then we capture an image and it gets to our retina and then to the brain for comprehending the image, for comprehending what we see. So in this case, somebody has gone to see the Taj Mahal. So the right eye can clearly see the Taj Mahal and there's a clear picture of Taj Mahal right in front of us. Whereas the left eye is not able to see the Taj Mahal clearly, even after the best possible correction. So with the best possible correction also, the child is not able to see perfectly the image in front of the child or the view in front of the child. So in this case, suppose one eye is seeing clearly and the other eye is not achieving the perfect vision. So the patient's first and foremost complaint is either double vision or shadow. A shadow image might be appearing due to the blurred image being seen by the fellow eye, the amblyopic eye. If this persists for a longer period of time, suppose this continues for 3 to 4 years and the child was unable to explain this problem to their parents or somehow they did not go to any eye care practitioner, then the dominant eye will take over and the amblyopic eye will go under suppression. So the child will always see the clear image, a clear view, a clear visual acuity, but it is no way a reliable measure because the child is never getting to know that he is amblyopic until and unless he gets screened and he gets examined by any optometrist or ophthalmologist nearby. So Hippocrates was a great philosopher. In the 450 BCE, he stated that when the doctor sees nothing and the patient sees nothing, the diagnosis is amblyopia. So amblyopia remains as the diagnosis of exclusion. We have to exclude things like he does not have any condition related to cornea, any condition related to lens, neither to the retina. Even then, he's not being able to see clearly. This might be amblyopia. Then they do all those tests and then they confirm it and diagnose it as amblyopia. So coming to the case, these are the case details. The patient ID was 14931. She was a patient from Gurugram. Her age was 15 years. She was a student, or we can say a boxing player. She was going for nationals. But her chief complaint shows blurred vision, photophobia sometimes, and double vision in the left eye. So it was present since 1 year only. And the major concern was difficulty in sports activities as she was a boxing player. Upon taking the case history, the general history was normal. The family history was also normal, and she was not allergic to anything. No history of any head or ocular injury. No history of past illness. The birth history was also within normal limits, and surgical and laser history was nil. But history of amblyopia treatment shows following occlusion or patching of better eye since 1.5 years. So she was following patching of the better eye since 1.5 years for the treatment of amblyopia, but still she was not getting any proper treatment. Her nutritional status was normal as she was a sports child. Then we took the visual acuity of the child, and the vision in right eye was 6 by 24, improved till 6 by 6 parts, and in the left eye it was 6 by 60, improving till 6 by 36. The near vision shows N6 in the right eye and N18 in the left eye at a 30 centimeter reading distance under normal room illumination. Then we conducted refraction, and the retinoscopy findings were follows: minus 0.5 diopters with minus 0.75 diopter cylindrical in the 90-degree axis of right eye, and minus 2.75 spherical only in the left eye. Then the final acceptance was nearby that only, and she was improving till 6 by 6 parts in the right eye and 6 by 36 in the left eye. With near vision achievement was N6 in right eye and N18 in left eye. Then we conducted the external examination. So external examination shows the face normal, head posture normal, ocular position also normal, ocular motility was full, free and painless in both eyes in all directions. Then we conducted the slit lamp exam and found it to be within normal limits. Our ocular adnexa was flat, conjunctiva was normal, sclera was normal, cornea was clear, anterior chamber was normal in content and depth. Iris was normal color and pattern, and no RABD was shown in the pupil. We conducted the retina evaluation. Retina was also fine, and there was no PVD, and the media was also clear. The macula was normal, and the fundus is within normal limits. So after all this examination, we could not find any exact cause of her symptoms or her complaints. Then we went for binocular vision evaluation. So upon binocular vision evaluation, we found the stereopsis to be 800 seconds of arc, both for dot test showing diplopia with 5 dots and cover test being ortho for distance and near. Her NPC was 14, 10, and 12 centimeter with RAF ruler. NPA in the right eye was 9 and 12 centimeter. In left eye was 12 and 14 centimeter. In both eyes, the ocular unister was 10 and 14 centimeters. Her MEM retinoscopy shows in right eye plus 0.50 diopters and in the left eye plus 2 diopter spherical. The NRA and PRA conductors was plus 4.50 and minus 9 respectively. PFV was the following and NFV was as following in the distance and near. So after the thorough binocular vision evaluation, we can definitely say that the right eye was only myopic, whereas the left eye was anisometropic amblyopia. Why anisometropic? Because there's a difference of refractive error in both the eyes, which is causing the amblyopia to the child. So the plan of management was first and foremost was glasses with the new refraction with which she was able to achieve vision of 6.6 in right eye and 6 by 36 in the left eye. Then occlusion therapy was replaced by active vision therapy because she was on occlusion therapy since 1.5 years. So then we shifted her to active vision therapy with heart chart, Marston Ball and vision therapy software so that she could be able to do it at their home also. And we planned the review after 1 month. Then on second visit, we found the vision of right eye to be 6.6 and on the left eye to be 6.12. So as we can see, the vision was improving very much within the 1 month period also. So the near vision was N6 in the right eye and N10 in the left eye. So near vision has also improved. We did the refraction again. So these are the refraction findings, but we did not change the glasses yet. We advise her to continue with the same because it shows only the difference in left eye, and that too was not very much and was minimal. So we can change the glasses later on. So we advised not to change the glasses, and active vision therapy was continued and the review was planned after 1 month. Then on the third visit, she was showing 6/6 in the left eye and 6/6 in the right eye. Although left eye was being not able to read three letters out of the 6/6 line in a Snellen's chart. And in the near vision, it was at N10 with English letter reading chart at 30 centimeters under normal room illumination in left eye, whereas right eye was 6 N6 only. Then we did the refraction, and these are the refractive values. So here the refractive values might differ a little. So we advise the patient to change spectacles now. The refraction has changed and the vision therapy is continued because she was only improved till 6/6 minus 3 in the Sneller's chart. Then we plan the review for 1 month. So these are the final BV evaluations we did. Her stereopsis has improved till 85 seconds so far. EOM has improved with full free and painless in OU. And cover test was ortho for both distance and near. IPD shows 26 centimeter in right eye and 28 in left eye. AC by A ratio was 5:8:1 calculated method only. NPC was 10, 5 and 8. NPA and MEM retinoscopy also shows improvement in the and the NRA and PRA was plus 3.5 and minus 8. So the last and the main thing which we should all be focusing upon was the patient experience. So as we know, the patient was following patching till last 1.5 years. So can you imagine patching your better eye for the last 1.5 years? So many days she was following the same routine continuously, and still she was not getting any much of results. So she was having discomfort with them, and when she came to us, she was having photophobia, diplopia. So now she was relieved of those symptoms, and she shows no discomfort, no photophobia, and no complaints of diplopia also, no blurring of vision. Her stereopsis, hand-eye coordination, and visual abilities improved significantly because active vision therapy is something which focuses on all aspects of vision rather than just focusing on the visual acuity. It also focuses upon the contrast vision, the 3D vision, which we call as stereopsis, and the crowding factors also. So I would like to talk about that the traditional approach was patching of better eye. So I suppose somebody tells me to patch my better eye and go and work with the amblyopia eye. So the amblyopia eye was already getting me a blurred image, a blurred vision for anything, whatever I do. So I might not be able to do it perfectly. So it creates difficulty in daily life tasks of those patients with patching. And the main reason patients drop out of the patching modality is cosmetic embarrassment. If anybody asks me that you have to patch the eye and then you have to play with friends, then you have to do all your normal activities, I might not be able because it is associated with a lot of cosmetic embarrassment. You cannot wear a patch over your eye, which was already giving you perfect vision, whereas the other fellow eye was not giving you a good vision. Then it has extremely slow result. As in this case, it was the patient was following till 1.5 years and not much of the results were shown in it. Then it has a risk of reversal. The eye which is patched might develop amblyopia, which is reversal amblyopia. So it has a risk of reversal there, and the patient compliance is poor. Suppose the patient has to perform patching for at least 1 hour, 2 hour, 3 hour, or 6 hours per day, and that too for a suppose a year long of the modality. So it is a huge commitment, and the patient age group was not much of compliant to this modality. So we need to shift to the advanced approach. We need to shift for whatever is better for the patient. We need to shift towards the betterment of the patient only. and do not stick towards the traditional approach. So what does vision therapy use? Vision therapy uses therapeutic lenses. It uses prisms, it uses filters, occluders or patches, electronic targets with timing mechanism, balance boards, vision therapy software program, a variety of spatial tools designed for specific and unique vision therapy activities. Now here in the images, as you can see, the red and blue glasses, they are called the anaglyphs, which are used during the performing therapies via vision therapy software. And to left of that was a screenshot image of what all exercises you get in a vision therapy software. So it has exercises for convergence, divergence, amblyoptic exercises, exercises based out of dichoptics also. And it is an individualized approach. The active vision therapy is individualized approach, and in each and every patient, it is not generalized like you have to, everybody has to do patching. No, it is individualized according to his and her vision, his and her visual abilities, and her his or her visual capabilities to reach and provide the best for the patient. Now, the biggest myth in amblyopia is people used to believe, okay, they have been told it is too late or you have to live with it. But they have now benefited from vision therapy. Why? Because there is no age limit for treating amblyopia via vision therapy. I would like to repeat it again. There is no age limit for treating amblyopia via vision therapy. Patient of all ages can benefit from vision therapy, whether it is a patient of 8 years or it is a patient of 80 years. The result would be similar unless and until he has opted for vision therapy earlier. It was proved by Pedig in 1997 study. Now, the nature of the therapy program varies with the condition treated. So everybody's therapy program is individualized and is specialized only for that candidate, only for that patient, based on his or her condition. Now, the most common question is, what is the goal of vision therapy? How do we know that it is the end point? It is the point where we need to stop the intervention. It is the point that the treatment is successful. So a happy patient is the goal of vision therapy. We just need to relieve the patient with the symptoms and maintain the binocular system, the binocularity of patient's eyes. Then it is the goal of vision therapy. It is the end point of vision therapy where the patient is happy and you are also satisfied by the binocular abilities that has increased or achieved within the patient. So thank you. It was all about the case. If anybody has any questions, you are open for discussion. Please post in the comments and I would be very happy to answer them. And somehow if we get stuck due to the time limit, I have attached my contact information here. You can always reach me there also. Thank you, Samagya. I think I would like to take a break here.
Thank you, Mr. Puneet, for this informative session. And also thanks to all the attendees and participation and for patience. Now we are to begin with our discussion session. So if you have any queries, then you can write it down in the comment section below. We'll just wait for a few more minutes, and then if you have any queries, then you can write it down. If not, then we'll move forward with this webinar.
If anybody has any queries or any questions, please open up. I would be very happy to answer them.
Well, I guess there are no any questions right now. Okay, so we waited for a few minutes and there are no any questions till now. So I guess there are no any questions. Okay, uh, there's just a one question. Should I read out the question for you?
Yes, please, it would be great.
In case of anisometropic amblyopia, if we balance power of both eye like normal eye to same power, how much it is effective?
Suppose the two eyes were, suppose it was an isometropic amblyopia, and you were talking about balancing the power in both the eyes to be the same. Okay, so first of all, the eye which was having clear vision would not be getting clear vision now. So it will provide the same effect as there would be with patching only. So there would be no individualized therapy. There would be uh, no active vision therapy involved in the process. It would just provide you the benefits that were same as the occlusion therapy, same as were in the patching therapy.
Okay, thank you. Um, there's one more request. Thank you for such presentation. Can you please summarize your presentation?
Yeah, so my main aspect is that we should not restrict any patient. Suppose the patient's age is 25 years, we should not restrict for even a minute that he could not be getting any treatment. We should always remember that age is no limit for amblyopia, and we have to fight our best against amblyopia. We need to provide the best for the patient so that he gets the improvement faster, and then even your referrals will start to increase. And talking about the case, the patient was a boxing child. I have a video. I don't know if it is if the audio might be audible on the Zoom or not. The patient was a boxing child and she was having difficulty into her moves and how she guesses the opponent's moves due to her lack of stereo acuity. But she has a keen to improve. So she was following patching since last 1.5 years. But still, even the visual acuity might improve to some extent following the patching. But the 3D vision, the stereo acuity would not improve much. So she requires those, and she requires the sports vision skills which are required for fighting the opponent and in the boxing process. But she was not getting much in her performance, and she has to apply for the national tournaments in the next year. So she visited us, and then we started the vision therapy. Within 3 months, she was able to achieve 6.6 - 3 with her best correction on. So my focus of the point of my focus is that everybody, each and every patient should get the newer modality, the advanced modality. So for that, we all practitioners need to understand that we need to constantly educate ourselves, and we constantly need to improve our practices towards a newer perspective where the patient gets benefit.
Okay, thank you
And
so much.
binocular vision is something that many of us neglect in our OPDs, usual OPDs, but we could at least screen patients with something. We could at least screen them for convergence, as it is a uh, it shows around study shows around 70% of your patients are convergence insufficient in a normal OPD. So that's it. I would like to summarize it that way only.
Okay, thank you so much. There's your next question. How can we learn more about vision therapy? Any online portal or book, please suggest.
Right now, I'm attached with a company called CureSeek. It provides vision therapy solutions. So you can just go to www.curesi.com. There you would be having an option to either log in or register. If you register, we have many webinars and many training sessions going on within us. So you just need to go to curesi.com and register. Then a representative will call you and provide you all the details of the webinars and the sessions being conducted nearby for vision therapy. Because only 5% of eye care practitioner worldwide. See, eye care practitioner is still a limited number, and out of that, only 5% are those who provide vision therapy. So the amblyoptic patients are obviously much large in number. We need to create an army to fight them, to fight the amblyopia.
Okay, I'd like to read out the next question. What are the components that leads to a success in amblyopia therapy in adult patients?
That is the success of the therapy in the patients.
What are the components that lead to a success in amblyopia therapy in adult patients?
Okay. So when we are talking about the adult population, the person should be having enough and ample time and should not focus only onto the vision therapy. Why? Because recently I had a patient and he was only focused throughout the day. He's performing all the exercises, so I have to somehow limit him that you do not need to do this all day. Okay, you have to perform this either half an hour or 1 hour only. You do not have to perform the exercises all day. So that was first point, that you should not overdo anything. Then the second one was, the patient should be keen enough to do the exercises. He should not be neglecting, okay, today I have to go somewhere, so I cannot do today, I would do it tomorrow. So you have to constantly see and motivate the patient that it is a commitment for daily needs and you have to perform it daily. If you perform it daily, only then it would be effective. So the adult population might be a little going and busy onto their own responsibilities. So first of all, during the patient selection, you please notice that if the patient is not too busy to perform the exercise and he would follow the instructions that were provided by you. So these are the only one. Rest all are same for all the ages. There's no age difference under any of the treatment.
Okay, what are the effective vision therapy for amblyopia in old age?
For amblyopia in old age, we first need to see whether the older age patient is complying or not, because sometimes what we see is the patient is not much into the education sector or either not much into the technology sector. So we need to see the need of patient and how well the patient can adapt to vision therapy. Only then we can provide vision therapy to him or her. So first of all, you need to see if the patient can easily perform those Marsden ball or heart chart at home, or if he or she is having a computer system at home, or can they perform the exercises. And if not, insist if they have someone with them who can help them out, because they are a little lag behind in technology. So they need, sometimes they need somebody to help them out in the technology sector only. So it is better if they have somebody to help them out if some error strikes in or any kind of mishap happens in the computer system only.
Okay, there is a next question. What kind of therapy will you suggest to preschool children as they don't pay attention to what we say or they are afraid?
Sorry, you might have to repeat it. As they don't pay attention to.
Okay, as they don't pay attention to what we say or they are scared to.
Okay, so in that case, we need to check whether
Excuse
the.
me, Puneet sir. Puneet sir, can you please share your video
Yeah,
for
yeah, sure.
cam? Yes.
Is it visible now?
Oh, yes, it is perfect.
Okay. So the question was regarding the infant population, the child population. So into those, we need to see whether the how much are the parents interested, because they are the ones who's going to motivate the child to perform the exercises. So we need to check how keen are the parents regarding the treatment of their child. So if the parents are much keen, they can obviously motivate the child to perform exercises, to perform the cards and perform the therapy at home. But if a child is school going and is verbal, then it is definitely a very great approach. Why? Because the patient himself is involved into the therapy rather than somebody else trying to drive him into therapy, trying to uh, place some balls, asking him to separate them, and the child might be crying even following patching also. So we need to see all those factors, and it is always better if the child is verbal. Then we start the vision therapy.
Okay, thank you so much. Well, I guess we have answered many of the queries now. So there are no more questions right now. So here I announce the closure of the discussion session. At last, if you have any queries, then you can just unmute yourself and I'm sorry, you can just write it down in the comment section below and I'll read out the question for last time.
In the meantime, I would like to thank Kapilji and the entire team of Mero Eye for this wonderful initiative and how much you guys are passionate towards learning in optometry. Seriously, this kind of dedication I have not seen since a couple of years into the Indian sector. But you guys are doing great into educating the youth towards optometry.
Thank you so much. Well, here is a last question.
Yeah.
So I'd like to read out it too. Which one will you suggest, patching or atropine drop if child is unresponsive?
See, patching is still safe rather than atropine penalization. Why? Because atropine is still in studies that how much percentage do we need to prescribe to the patient. So 1%, 0.1%, 0.001%. So it is always into the controversial part. So it is always better if we shift towards the patching rather than atropine. Why? Because atropine might have some side effects or might be not the child might not even comply with that. So it is always good if you avoid atropine and go for the patching. But if the child is verbal and he or she can go for active vision therapy, then it would be even better. The results would be faster then.
Okay, thank you so much. So here I announce the closure of the discussion session. Before ending today's session, I'd again like to express my sincere gratitude towards the presenter, Mr. Puneet, and all the attendees. Also, I'd like to appreciate all the helping hands for the iTalks program. Herewith, I am ending today's session, requesting all of you to drop your reviews and feedback. And at last, I'd like to request Mr. Puneet for your feedback too.
First of all, thank you, Samagya. You have been a wonderful host for the session. And to the Mero I team and the e-learning initiative, I am always a fan of you guys of the iTalks. So keep it up and keep the sessions coming. I'm always attending your sessions, and it has the newer topics and the newer and the youth speakers also. So keep it up, keep the sessions going, and then we'll be following you live onto the YouTube channel.
Thank you so much. Uh, okay, thank you everyone. And stay safe and keep in touch. Thank you.